My name is Urs Fischer, and I'm the chairman of the Department of Neurology at the University Hospital in Basel. And I'm here at the European Stroke Organization conference, and we are discussing these exciting results of the subgroup analysis of the RACECAT trial. So first of all, congratulations. These are important informations. How do you explain that there is no major difference in transport patients and those going directly to the next local stroke center? I would assume that patients going to the next stroke centers, they would have a better outcome because they are probably treated faster by physicians. How do you explain the lack of difference?
There's a trend to better outcomes for those going to local centers. In the univariate analysis, the shift analysis for ranking and mortality was statistically significant. But then when you adjust the results for age, NIH, and baseline volume, there are no differences. So I think probably it's a balance of the patients. They have faster attention, and they can be better controlled in the first time hemodynamically and of the complications, but probably then going to a comprehensive stroke center with higher capabilities, this would benefit more the other arm of the study. But it's difficult to say. They all have like bad outcomes, so probably.
So this is very interesting. So do you have any standard protocols in your hospitals regarding treatment of patients with hemorrhages? So we would assume that those patients reaching the local hospital sooner, they have a better antihypertensive treatment or other treatment. So what is there a protocol which is established in all hospitals in your region?
We all the hospitals here in Catalonia, we are all certified by the ISO, so we all follow the ISO guidelines for intracranial hemorrhage and the American guidelines. So that's our protocol in the Catalan Stroke Network, and it's common for all the hospitals. So there may be no differences in the first attention of the patients. We had the same hypothesis than you, that probably patients going to Mothership to doing larger transfers may have higher volumes at the beginning because the lack of control of hypertension during this time, and we have found the same baseline volumes for both groups. So that was another surprising result of the SOAP analysis.
Were there any safety concerns? So for instance, patients who have been transferred to a further distance to a thrombectomy center, did they have any an increase in complications? What was the finding of RACECAT?
Yeah. Safety in the hemorrhagic stroke was the main safety outcome in the main RACECAT trial. It was evaluated with a DSMB in some predefined times in the main RACECAT trial, and it was never a safety issue. We will never have a safety issue about that. But when we look into details of the results, we see higher transfer complications in patients going to Mothership. The complications were registered in a predefined way. We registered vomiting, seizures, orotracheal intubation, RACE score worsening, and level of consciousness worsening. And the complications that are significantly different are vomiting and neurological worsening during the transfer. However, having those complications did not imply worse outcomes at the end and worse mortality at the end when you evaluate them inside the multivariate analysis.
That is very interesting. So may I kindly ask you, in your country or in your area, the ambulances, are they equipped by paramedics or are there also physicians?
They are equipped by paramedics. They are not allowed to administer treatments during the transfer. This is really important and a very good question, because here 90%, more than 90% of the stroke transfers are done by technicians. So they are not allowed to apply treatments during the transfer. So they cannot control the blood pressure during the transfer or administer a treatment for vomiting, for example.
Okay, that is an important information, because that is different in other countries where sometimes the paramedics are even allowed to perform an intubation or at least giving intravenous medication. What is now the next step? So what do you think should we do in future? What is your take out of these results?
Yeah, I think the main result, the main conclusion of the study is that is in the line that what RACECAT taught us. The main study is that we should better improve the whole stroke code system, not only the hospitals with thrombectomy and thrombectomy capable. It's very important to have fast attention in local centers, good door-in, door-out, and good transfer, secondarily transfer for hemorrhagic strokes when needed and when they need neurosurgical treatments or whatever. And we need to have good times. If you have a good circuit, then all hospitals work properly. But going into the topic today, the hemorrhagic strokes, I think one conclusion for the future is the paper or the role of mobile stroke units. This might help, and this could lead the decision in the hospital level. But we all know it's difficult to apply in a lot of settings, and however, like you said, we need to give attention to hemorrhagic stroke as fast as we can, because long transfer did not show differences, but there are slight differences, not yet significant, to take in mind.
I fully agree with your point regarding mobile stroke units, because performing a CT in the ambulance would then also allow to first refer the patient to the next hospital and to get proper treatment. One last question: was there a difference whether it was on the weekends or during the nights regarding 9 to 5 regular day times? Could you observe any differences in rates?
Yeah, we evaluated that, and there were no differences between daytime.
Okay, so thank you very much for this very great information, and congratulations again for this great sub-analysis of the RACECAT trial. Will we find it published somewhere soon, or?
Yeah, soon, but it's still under construction.
Okay, fantastic. So please keep going. Thank you very much.
Thank you.